been part of what we have been practicing. And to say that we don't have structural racism is something would be disconnected. And as an example, home dialysis in the past, let me give you an example. The African Americans or Black Americans, they represent 13 to 14% of the US population. Yet among dialysis patients, they are overrepresented, 30 to 35%. And it's 2 to 3 times more likely for an African American, for a Black American to be on dialysis. Yet home dialysis was less offered to African Americans until recently. So it's a great development. We're very proud. So Dawn again is here to tell us her story against some of these trends. And the ETC model and others are here. They're not going to resolve the problems overnight, but it's a very important step to that direction, right? So how we can team up again to go after some of these problems with equities and with diversity inclusion in medicine, especially in nephrology, especially in kidney care, kidney medicine, renal medicine. And I'm very happy and proud that these new developments have been happening, and I'm hoping that we continue to expand on
it. Thanks, Dr. Kalantar. I was just interested in your perspective. I asked Dawn this question, and I'll ask you as well. What could policymakers change to again continue to try and decrease these health disparities in this population?
Well, as we discussed, to make everything available for everybody, regardless of certain biases. For example, looking at certain patients that, he or she is not a good candidate for this or that therapy or for this or that discussion. When I talk with the patients, to think that this patient doesn't understand this level of education about diet, about phosphorus burden, and I have to tell the patient that, hey, you take these pills, and without explaining why you take so many pills for phosphorus controlling, right? So I need to really be convinced